Well, thank you very much for having me here to speak. And I will make one comment about that last slide. Is there clearly, in my mind, doesn't need to be a randomized clinical trial versus surgery for PDA ligation. It's a better modality. It's just like ASD devices. It's not a surgical procedure. I have no disclosures to make, and hopefully, we can get through this talk, and everybody will be awake by the end. But we've already seen a lot of this data, and I'm going to go through it quickly. But ultimately, from my standpoint, from the congenital heart surgeons' data from looking at cases from 1994 to 2000, the outcomes for hypoplastic left heart and the Norwood procedure are very poor. And we saw the data. It's only about 50% of these patients actually get to the point where they can get a Fontan, but the mortality rate's very high. Recently, there is another study that just came out that is being published in the Journal of Thoracic and Cardiovascular Surgery, and it was accepted last month, but looked at a new way of what is called propensity analysis, so that you can look at registries and get similar data. And ultimately, from that propensity analysis from the Congenital Heart Surgeons Society, really the graphs are very similar to the SVR trial with very poor long-term outcomes from transplant-free survival. And utilizing a hybrid approach is clearly a beneficial thing, and we've seen a lot of that data from here. This is just one of the first reports from Columbus that Mark had shown. And interesting in that there was really no contraindications to the size of the patient. And these were able to be successfully implanted as small as 1 kilo. And then ultimately, you could do it irrespective of the aortic size, and you could do it for multiple other problems like transposition. You can do it for other biventricular repairs like interrupted aortic arch. And it allows you to allow these kids to grow. And as we've been talking about, these premature or small birth weight kids are at high risk of having serious complications. And so when you look at hypoplastic left heart, and part of the problem, and I think it's, to be honest, it's a surgical issue because we're more interested in 30-day mortalities, we need to start looking at long-term outcomes and what is best for our patient. And when you just look at the neurologic and multiple studies in developmental morbidity from hypoplastic left heart are very severe with decreased IQ scores.
Alistair. Those numbers there, they don't relate to the IQ of the surgeon doing the operation, do they?
Well, we all know
that was
that's
the patient.
low.
Sorry.
Okay.
Sorry, it's the patient. Sorry.
Yeah, I should have made that clear. That's why we do hybrid procedures, and that I don't have that IQ score, but those are much higher. But ultimately, there's a lot of morbidity that occurs with these patients that is really underreported. And when you take these premature kids that have lower gestational age, not only looking at the Society of Thoracic Surgery, your likelihood of having mortality odds ratio is much higher until you get to about 39 weeks gestation. And that's a good surrogate for low birth weight. And then ultimately, when you look at the neurologic outcomes for these smaller kids after cardiac surgery in infancy, with a multivariate analysis, all of these kids with lower your birth weeks of gestational age, you have increased decreased neurologic outcomes, and that gets better the older you get. And then ultimately, when you look at cardiac surgery specifically for low birth weight and looking at the STS data, the smaller you are, so the 1 to 2.4 kilo kids, you have a significantly decreased long-term survival. So this is some of the similar data that was done in that propensity. This is not published data, and I was privy, but this is the work really on this propensity analysis, which is a way to rank the different cases and have them control against each other. And looking at survival, it's better for the hybrid procedure in the congenital heart surgeons database for these low birth weight patients. And granted, the survival isn't great, but the difference between the survival for a patient who has a Sano or a BT shunt is clearly much better. These kids are very fragile. So the things that you can do that are going to decrease that impact to the patient is clearly going to have a benefit. So really, just to get into the technical things, and we've heard a lot about this, but really from our standpoint, and I think this is really the same case that which has been really taught by John and Mark, is that you really want to put the bands on before you do the stent. You can also always leave them on prostaglandin. That is done in other places. For these kids in general, you're going to use the smaller Gore-Tex tube graft. You're going to use a 3-millimeter tube graft. And really, I think one of the things is that we always have heard from Mark talks about, this expected 10-point decrease in the blood pressure and the decrease in the O2 sat. But I think the other aspect is these kids are small is actually what you want to see is just a crimping of that pulmonary artery and allow them, and they'll always be able to grow into those bands. So you don't need to have the perfect circulation for these kids. They're going to do fine with just a little bit of obstruction of those bands, and you can manage them, however, very easily. It's better to have a slightly looser band in my mind. And then we've, the PDA stents, and I don't need to talk to you guys about all of this, but really from our standpoint, you can use it balloon expandable or self-expandable stents. And again, doing it through the pulmonary artery in our case, unlike in the Gießen experience, is clearly the best. You've heard about that even from today's case, that live case presentation. From my standpoint, trying to avoid stenting open that tricuspid valve in a very sick heart is clearly a beneficial thing to do, and gives very easy access. You're not dealing with small vessels. So the big issue is the ASD, and this is a report by Ralph from our Columbus experience, and really looking at the difficult and the challenging aspects of the ASD and how you manage that. And so a lot of times you can do just a balloon septostomy. Usually there was the concept of waiting until the LA got bigger so it made it easier. I don't think that's the best way to go. And I'm going to explain the way we are doing it now at Cedars. But ultimately, these ASDs are very challenging. They can be thick, and it can be very difficult to get a good result. And in as many as 30% of these patients can have some significant complications from that procedure. So really, the way we look at it is you want to do this during the hybrid stage 1. You have easy access to the atrium. You put a purse string in the free wall. And we talked about yesterday the utilization of epicardial echo to guide you. And that is a very useful tool in the cath lab while you're doing this hybrid stage 1. And we use an 18-gauge needle, and I put a slight bend in it. This is something that Z had pointed out many years ago. You take the Bovie pad and you rough it up, and you can see how that part here is now roughed up. That allows you to have some echo lucency when you put it in, and it helps guide you. The bend helps you because then it gives you the fine ability to move it, and you want to really make sure that that bend is along one of the flat edges of the needle right here, so that you know how to manipulate it, and you can do small manipulations, but that needle is sharp enough to go across any of the atrial septum. Here is an atrial septum. We're doing a measurement to figure out from the echo. We also will be doing angio at the end of the deployment of this, but we want to figure out the size and where we want to place it. And then ultimately, you just put the needle and then a wire into one of the pulmonary veins. This, to be honest with you, shouldn't be done by a surgeon. I think the first time I did one of these with John, I put the needle in the wire and I put it into the pulmonary vein, and he was convinced that I ruptured. I didn't, but you get lucky. And then ultimately, under echo guidance, we'll deploy the stent. We'll look at the gradient across with very low gradient, and then at the end we'll have an echo, and you have this big piece of metal in the heart. But this ultimately is very easy for us to take out at the comprehensive stage 2 procedure. It doesn't cause any vessel injury to these small kids, and is, I think, the approach for all of these atrial septums. You do pay the piper, of course, with a hybrid. Removing that PDA stent, everybody complains about it. It does push away, especially with these littler kids. The distance can be you have to deal with. The atrial septum clearly can be difficult, but that per-atrial approach is beneficial. And a complete repair, of course, at this age, it's a huge insult to a small kid, and then ultimately you will have aortic arch issues in the later. And so the big thing for me is these neurologic outcomes, and there's clearly a potential benefit when you're doing for these smaller kids. Their survival is better when you look at the congenital heart surgeons, but I think the long-term outcomes are going to be better. You're going to have less anesthesia time, you're not putting them on bypass, and you're going to have less of an inflammatory response. And again, I think the only concern is the retrograde arch flow, but that's something that you're going to follow with time. And I think there are modalities, if you do get that you can still go in and open up that retrograde arch with a stent to buy you some time. And really what you're looking, in my mind, is deferring the impact to this kid as long as you can to do a better repair. So I think the future directions, we need better outcome data. I think the Congenital Heart Surgeon Society is a place where they're doing this propensity analysis, and it's been very good. But we have to start looking at long-term outcomes, and mainly neurodevelopmental and cardiac function. And ultimately, with time, and I have made this comment, that I actually think the future of hypoplastic left heart is not a surgical issue. You're going to have biodegradable stents that you're going to be able to place in. And I would love if we had the internal flow restrictors and that you could put them in the PAs, and ultimately you could actually argue the fact that in the future, nobody will be getting a Norwood and nobody really would be having a surgical correction, and there would be a catheter-based approach. I know that's blasphemy, but it is what it is. So to me, we need, hybrid appears to be the best outcomes for these small kids. And we, as a group, talking about surgeons, have to get on board with this concept of the heart team and have a role. And again, that example of using that atrial stent is also a great way of dealing with ASDs when you have an ASD with a pulmonary valve that you need to do. You use that same approach, you don't need to stop the heart. So there's ways that we can work together to get better outcomes and decrease that impact to our patients. And ultimately, from my standpoint, it's the Rugby World Cup. And again, we all have to work together as a team. And if this is New Zealand and they do this war dance before every game, and I'm Scottish, so this is, in my mind, very appropriate.
William Lawson's. No rules. Great Scotch.
Thank you very much.